Bennie Jeng. I'm the professor and chair at the Department of Ophthalmology at the University of Maryland School of Medicine in Baltimore, Maryland. My practice is focused on corneal and external disease, both corneal surgery as well as medical management of corneal disease, especially infections of dry eyes. There's been a lot of recent developments in dry eye that have been very, very exciting. I think on the medical side, there's been some new medicines in the United States, as well as some new therapies to help treat these patients, including lifitegrast. And I know that various preparations of cyclosporin are coming out. There's a new intranasal tear stimulator that is approved in the United States, which is new and also rather exciting. For me, I think the biggest development that I use in my practice is the popularization of scleral contact lenses. They really help my severe dry eye patients who have chronic Stevens-Johnson's disease as well as graft versus host disease. The other major development is that we have a better understanding of what dry eye disease is in terms of the mechanisms and what causes it. And one thing that's come out of this is a better understanding and popularization of something called neuropathic pain. That's commonly misdiagnosed as dry eyes, but really is derangement of the nerves in the cornea that lead to what seem like dry eye symptoms, but really are not. And recognition that a huge proportion of patients who have dry eye actually have neuropathic pain is a huge development and advance in this field. So the biggest unmet need, I think, is access to the right tools to treat dry eyes. And for the really chronic, severe dry eye patients with GVHD and Stevens-Johnson's, I think scleral lenses are a great option. Unfortunately, not everybody has access to this great tool. And if we had better access, I think a lot more patients would be able to be treated. The other important thing is understanding and recognizing neuropathic pain. And how to treat that. It's in the United States, we call it pain without stain. And so patients present with significant discomfort, sounds like dry eyes, been treated with artificial tears and nothing really works. Really, to get to the root of the problem, we need to treat the nerve pain. So gabapentin or pregabalin are excellent treatment modalities, but they are systemic treatment. Interestingly enough, we know that neuropathic pain of the eye is correlated with chronic pain syndromes throughout the body, including chronic lower back pain and other entities. And so treating the eye sometimes actually can treat the entire body. I think as we gain a better understanding of the mechanism of dry eyes in terms of the inflammatory cascade, we will have better options to target specific molecules that will help. They've already done that with a lot of the newer anti-inflammatories, especially lifitegrast is targeting a different mechanism, but I think we still have to have a better understanding of that. I'm a huge proponent of autologous serum for treating dry eyes. And my question always has been, what in serum is it that makes it work for dry eyes? Which factors in the serum are the most helpful? And I think we're moving towards a better understanding of that. Well, along the lines of dry eyes, I think that there's been a lot of very interesting discussion about new developments, new technologies in dry eyes. It sounds somewhat mundane, but dry eyes afflict so many people in this world that's actually much more relevant to our general practice than it is for more specific and niche entities that we find fascinating. So there's a lot of interesting things in dry eye that have been going on here.